This is No Operating Manual, a podcast about building healthcare companies when there's no one clear path and no operations manual. My guest today is Torrie Fields, founder and CEO of TFA Analytics. Torrie's work is shaped not only by years spent inside health plans, but also by personal experience navigating serious illness. At TFA Analytics, she focuses on helping organizations understand the total cost of care and build systems that better support people with high needs. Today, we're going to talk about how data, policy, and lived experience come together in that work. Torrie, thank you for being on No Operating Manual.
Thank you for having me.
So we're going to get right into your experience. You've built more than one company, each in a different moment of your career. Can you tell us a little bit about your startup experiences?
Absolutely. I have an extensive amount of interest in building something from scratch. So when I was 15 years old, I actually started my first nonprofit organization that focused on helping educate peer counselors and resident advisors at colleges about the risk factors and warning signs of suicide, and helping to ensure that people had a hotline that they could call into with educated standards around who picked up the phone. So that was the early days. I went on to found another nonprofit in partnership with the Oregon Health and Science University Center for Women's Health that connected nonprofit organizations to data analysts, so that we could develop legislative concepts that would improve women's health across the country. And that really got me into the work that I've been doing in my last two companies around supporting people with serious illnesses by empowering and enabling provider organizations to better access their own data and therefore then get better access to reimbursement for team-based care.
So within those two company experiences, tell me about the differences between when you started your first company and then when you started TFA Analytics.
So we started Votive Health just before the pandemic. And so the company founded in January of 2020. I would recommend to any startup founder not to found a company 2 months before a global pandemic where the world shifts completely. And we actually went the route of venture capital. So got investments from some fantastic venture capital organizations to provide us seed funding, and then some friends and family, so strategic angels who actually invested in the company. And our second time around with TFA, the work has been largely bootstrapped. And so we have some additional grant funds or grant dollars from philanthropic organizations that underwrite a lot of our development work, but we are getting paid revenue from customers this time around. So what's been interesting about those two experiences is really what the risks and benefits are in taking venture capital versus waiting to take venture capital until you have proven product market fit. So the first go around, there was a lot more access to venture capital for seed stage founders, especially with a group of people who had proved concept inside of insurance companies like I had. And that enabled me to build a pretty rock star world-class team to start thinking about how we designed a solution to this big, hairy, audacious problem, which is helping people with serious illness get better access to care. The second time around, we actually started getting traction from customers before we figured out what the automated product really looked like. And so the design phase of this work is happening alongside actually having to deliver services to customers in more of an analog fashion. So as you can imagine, there are interesting pros and cons to that. You get a lot of lead time with venture funding, but there's no promise of product market fit. And there's really no promise of knowing how the operations is going to get built out right away, because you have to sort of wait until you know what your product is and who your market is. This time around, we've had different experiences where now we're shifting a team of people from an analog delivery model with a lot of customers to a more automated delivery model with a lot of customers. And that creates a lot of internal operational reorganization and operational infrastructure that needs to be built sort of on the corner of your desk as you're keeping the customer front and center.
Did you say that Votive was incubated within a health plan? Is that what I heard you say?
Votive was actually a concept that I partnered on with someone who is in venture capital, who was very interested in working with me personally to spin out my idea that I had already proven inside of a couple of health plans. So I've worked in the Blue Cross Blue Shield system for a long time. I had the opportunity to be supported by very understanding and passionate and innovative CEOs within those health plans. And so they actually allowed me to create something from scratch inside of the plan and then test it out on our members. So Votive wasn't incubated inside of a plan, but the idea had already really proven concept inside of two health plans. And so
Okay.
it was sort of right for spin out.
That makes sense. In your career, it spans, analytics, policy within health plans, and now you're founding a company. When you think about the through line, what problem have you been trying to solve the longest?
What I have found is that healthcare is too expensive to be this complicated. And I started out my career actually in patient access, so in scheduling for clinics. And the scheduler has a lot of power and a lot of power around the patient experience, but also a lot of power in the revenue optimization for an organization. And we often forget about solutions that are related to time and productivity. But time and productivity are what drive revenue for provider practices, coordinate care for patients and their families, and reduce overall healthcare costs for insurance companies. And so when I start to think about where my work has all had sort of a common through line, it is when the current scheduling system fails for the patient. And that is people who are older, people who have multiple comorbid conditions, and people who have very serious illnesses who need more time with healthcare. And so it doesn't really fit into the fee for service structure, and it doesn't fit into the expertise of just a doctor. That's when you need a team. It's when you need some time-based approach to reimbursement. And it's where quality and patient experience really matter when it comes to data.
Do you think that those schedulers know that they're at the tip of the spear when it comes to ROI or productivity?
I don't. I think that schedulers usually are doing what the system allows them to do, and they're following a protocol that somebody higher up in the organization has taught them how to do it. And I was given an opportunity early on in my career to optimize the schedule. And so when given that ability to optimize the schedule, I found some problems with how patients and families are treated when it comes to the time they get with their doctor. Having them wait in a waiting room for 15 or 20 minutes for their doctor without getting served. Not being able to get on the calendar for 4 or 5 months. That might work for somebody who is well, but when you have end-stage cancer, you can't wait.
That's so important. It's a good point. Going down the path, you've had personal experiences navigating serious illness alongside many years of professional work in this space. How have your personal experiences helped shape your thinking professionally?
Well, I'll start out by saying that I was diagnosed with cancer the day I lost my health insurance. So I knew right then that the system can fail you at any time. And I was delayed in getting access to treatment for 13 months. And so I knew I had cancer and I didn't know how advanced it was. So I sat there stressed, looking for a job, trying to get access to insurance, and knowing that I could not afford cancer treatment on my own because of the terrible cost it would incur. And I remember the early days of trying to get answers and taking out a credit card just to max it out so that I could get any access to treatment that I could. And this put a terrible burden on my caregiver, who also couldn't afford things, who had to take time off work. And he wasn't in a career. He worked a regular service professional job where you get paid if you show up. And we struggled. And what I learned was that I wanted to change the system rather than be part of it. I was on my way to medical school when I was diagnosed, and I changed my career completely to go into sort of the back end healthcare administration and contracting and finance. And that's when I found that my story really mattered because I got it. I understood that when you get diagnosed, you need access to care. And when you get access to care, it should come with a person who understands how to help you navigate.
That is devastating and also frightening. 13 months went by before you could access care. And so now, as you're thinking about that space, like how, TFA Analytics focuses on total cost of care, which is really abstract. How do you translate that work around total cost of care in decisions that can actually change, your experience or someone's experience in the day to day?
It's a great question. What the first job that I had in health insurance was actually in actuarial. And I'll say that I didn't know what an actuary was until I started to become one. And so I just knew that I wanted to get access to the data to really better understand affordability in healthcare. And where else do you get those data but to join an insurance company? And so what I started to learn was that people with serious illnesses admit to the hospital more often, go to the emergency room more often, and often have a bunch of doctors, which means no one is accountable. So from that perspective, you get this crazy cost in healthcare as people get sicker. And the solution is really out of sight. It's about upstream prevention. It's about proactive identification of patients. It's about helping patients and families understand what the alternatives are to the hospital or the emergency department, and in creating a quarterback or a central point of accountability for that person to access ongoing over time. And so when we think about total cost of care, we have to think about it from how much has to be paid out by the doctor, how much has to be paid out by the insurance company, and how much you have to pay out of pocket for your costs. And the solution to that are these really interesting care coordination models, like enhanced case management, specialty case management for people with serious illnesses, supportive care for people with cancer or for dementia or for heart failure, or things like palliative care, which are specialized team-based services for people with serious illnesses. And all of those things have care coordination at the center, are longitudinal, are team-based, and really focus on making sure that the person and their family have an accountable party that helps them navigate. And so that's sort of the way that we translate total cost of care into new contracting and payment models for providers who want to start delivering care coordination or supportive care or palliative care services in managing serious illness or high cost patients.
So your clientele, just making sure I understand, your clients are primary care physicians, or are they specialists or all of the above that are looking to add this as a wraparound service in order to make sure that their patients are being cared for? Is it all?
Yeah, it's all of them. So our customer base is largely health systems and academic medical centers who want to expand their offering for supportive care with their specialty practices or specialized palliative care programs. They're home health agencies and hospice agencies that are looking to move upstream and start to take on risk or start to deliver home-based primary care to people with serious illness. And we have a customer base of even area agencies on aging that are community-based organizations offering care coordination and case management to older adults.
It's interesting, again, seeing the broad swath of, from a patient perspective. So you're targeting providers with patients who have serious illness versus a lot of startups we see are targeting folks with a certain disease or condition state, and they're really wrapping around with those services. So you'll have a custom diabetes care management model and a custom cancer care management model, or a specific type of cancer care management model, but you're looking at it from the patient perspective and like the providers that they're primary care providers, really.
Yeah, that's right. And I think this comes from my and my team's experience on the health insurance side, where you can't contract with all of these different types of specialty providers in different ways. You need to see the through line in order to have it get administered through claims or to have contracting be a lot easier. And so what we're looking at are the services that make up care coordination, or the services that make up supportive care, or the services that make up palliative care, which means that it can be something that can layer into any of these diseases at any stage of disease, knowing that somebody with diabetes is going to have a trajectory toward serious illness, or somebody with early dementia is going to have advanced dementia in the future. So that allows us to be a lot more agnostic when it comes to our population, and also really focus on needs and services rather than your diagnosis.
I think I know the answer to this one, but TFA Analytics is in your name, right? So when you're thinking about the work that you're doing, what distinguishes the work that improves the care versus what really just looks good on paper? Like from an analytics perspective, things can look really different than the actual application of that in a care system, right?
Oh yeah, and I think the team-based approach to care is something that's really new in healthcare, and we pair that most often with something like a bundled payment or a per engaged member per month type of payment structure. And so from a data perspective, what's really important is tracking the touches with a person. So a common feature of what we put together are, when does somebody actually engage versus just be attributed? So attribution is payment, whether or not you impact or improve the life of that patient. And engagement is, you have to engage that patient and get them to consent to services before you start getting paid. So there's a real difference there where, you're on the hook for serving somebody and then tracking what you're doing in order to serve them. And that allows us to really monitor our provider performance and help them improve that performance so that they are able to sign up for things like lower total cost of care, or lower utilization of the ER or inpatient setting, or improved patient satisfaction, or improved clinical quality. You have to really start by saying, what is this person getting? And do the services this person getting match their needs? And we're very judicious about that, and make sure that we are helping our providers understand that these are things they need to track, not only just because we're trying to burden them with more reporting, but because this matters to your patient, the model you deliver.
It also must be a harder engagement model, right? Because oftentimes some of those who are older or maybe sicker aren't as easy to track. And so, getting that PE versus a PMPM would really, that is a risk, right? Like, you're basically saying we have a way to make sure that this person is engaged in their care, and this is how we do it. So what does that look like?
It's a great question, because the CMMI models are really moving toward a PEM-PM type model too. So you look at the guide dementia model, and they're really incentivizing you on beneficiary alignment. So you are on the hook for finding your own patients. And that means that from a communication standpoint, we need to be much better at messaging. We need to put the awareness of services into the hands of the patient and their family. And we need to have a multimodal approach to engaging and enrolling. And so you can't just have a passive list that comes from the health plan that says, oh, now there's an eligibility file that has identified people who are eligible for your services. Now somebody has to be good at picking up the phone and getting somebody to agree. And that means that the power really shifts to the primary care provider or the specialist or the healthcare system or the places where a patient trusts to get trusted information. And what we've found is that for things like palliative care, the highest engagement rate that you can get is when the referral is coming from somebody's primary care provider or their oncologist or their cardiologist or their case manager, somebody that they've already established a trusting healthcare relationship with. And I think that's so critically important to this engagement model we're talking about.
Thinking about your work now, and what lessons from those earlier builds have you carried forward, and what have you intentionally left behind?
Originally with Votive, we had focused on getting health plans to sign up for these models and these networks of care. We intentionally shifted our focus to provider readiness on the TFA side when we identified that there was a lack of standardization in the way providers deliver these types of models. And so that actually was a great lesson learned for me when you need to have a standard put in place in order to have standard reimbursement. But I also found that health plans really care about network adequacy and availability of providers when they're going to turn on a new benefit or turn on a new program. And so in order to gain the trust of a health plan case manager, you need to actually demonstrate that there are enough providers willing, able, and ready to deliver a high standard of care to their population. And so what I've left behind was this belief that providers are all delivering the same thing and really focused on how do we standardize our network and standardize these models so that the consumer gets what they're looking for and what they need.
Yeah. Network adequacy does not equal caregiving is really what it comes down to. Like you're not always going to get the same things. Moving that upstream a little bit. Kind of closing this out, what advice would you offer startups that serve high needs populations or are moving to serve those high needs populations?
I think especially now, if you're looking to raise money from your classic venture capital route, we all know now that AI is at the forefront of fundraising. And I would offer you some advice to identify where AI can improve processes and operations and even data collection and standardization, but where AI cannot replace high touch services and relationship building. I have learned that the way that we at TFA really think about data and analytics is what are the things that we can automate on the back end so that we have much more time when it matters, much more time in an engagement or relationship development model. You're never going to be able to replace person-to-person relationships or person-to-person communication, whether that's a B2B business or a direct-to-patient or direct-to-consumer business. And especially with the high needs population, they struggle with technology and really need a friend.
That absolutely rings true through a lot of different conversations that I'm having. Torrie, thank you so much for your time and your expertise. I really appreciate it, and best of luck to you and the TFA team.
Thank you so much.
Thanks for listening to No Operating Manual. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and a review, and don't forget to subscribe on YouTube. No Operating Manual is hosted and produced by Aaron O'Brien of Chemistry, a healthcare marketing and communication advisory. Visit our website at choosechemistry.com.